Good afternoon. สวัสดีค่ะ. It's my great pleasure to be here today to share with you on the topic of adolescent integrated service, test, prevent, and treat. I'm Professor Thanyawee Puthanakit. I'm working at Department of Pediatrics, Faculty of Medicine, Chulalongkorn University. We are starting with pediatric HIV services. And 5 years ago, we discussed among our team that our clients is growing up into their young adult period. Should we transition them to adult services, or should we transition ourselves to be able to provide service to adolescent and young adult? So we decided to provide service within our teams to capacity building us to be able to provide service to adolescent. So today I would like to share with you 3 cases that we have in our clinics and also services that we integrated and expanding in the past 5 years. And hopefully it will be benefit in terms of one of the model that can be applied to wherever your settings. This is the first cases, a journey of 22 years old girl. I know her when she was 8 years old. She lived with grandma and received ART. She grew up beautifully. At age 15, she started to have boyfriend and she get pregnant and have baby girl. She hoped to start her own family. However, she lost a follow-up for 3 years and come back when she was 18. She's very fatigued and CD4 only 46 cell. At a time, we start treatment for her with TDF, 3-FTC, and dolutegravir. After that, she get better. But however, her husband was get into jail because of the drug substance abuse. And also her daughter was taken away to live with other relatives. So she very upset and sad and lost a follow-up. 2 years later, she presented again at our emergency room. She had pneumocystis vaccine pneumonia. She's very sick, only 32 kilo. So we restart treatment. 1 year later, she still not get back on track. So we have a team meeting and consult with psychiatrist. She received antidepressant. She changed treatment to TAF, FTC, bictegravir because it's smaller pill site, and her grandma come back to support and she moved back to live with grandma. 6 months later, her CD4 growing up to 252 cell, she gained weight, she get job and had a wish to live with her daughter. In this case, this showing that taking care of adolescent, you need a good medicine, address mental health, waiting for her to have more maturity and matter of time that we not give up. How about other adolescents living with HIV in Thailand? We have a research program called Thai Papaya funded by Treat Asia, in which we have an aim to go back and follow up young adults living with HIV in 5 large HIV centers. Some of them had already transitioned to adult clinics and some of them continue in youth-friendly clinic. What we find is that when we tracked down 820 young adults living with HIV, 7.9% had died at a median age of 20.9 years old, mostly due to opportunistic infection. And many of them, we try to contact them with different ways, clinic visits, phone call, or tracing them from the national database. And what we find in the preliminary analysis showing that currently they are in the median age of 22 years old. 92% continue ART. However, majority of them receive NNRTI and PI. Only less than 20% receive integrase inhibitors. 1/3 had biological failure. So it means that we need a special care and also the follow-up in order to prevent death or to help them to resume biological suppression. The second case is a journey of 25 years old young man. He don't have any psychosocial problems. He very disciplined and come to clinics, visit every time. However, when he was born at 6 years old, he lived in orphanage home. And at that time, the access to antiretroviral treatment for pediatrics is very limited. So he had quite not a strong regimen. When he was 22 years old, he had a job. He come to clinic visit regularly. However, with his previous exposure to antiretroviral drugs, he had multi-class failure. even though he had tenofovir, FTC, darunavir, and DTG twice daily. With his accumulated of resistant associated mutations, he not be able to have viral suppress, and CD4 start to decline. So we decided to refer him to participating in clinical trial of new drugs, capsid inhibitors, lecanapavir, and optimized background. After receiving that regimen, his plasma viral load had suppressed for more than 1 year. The lesson learned is that we need a better regimen or a long-acting regimen for experienced treatment young adult who have resistant mutation, and also for maintenance with adolescents who have a long-term treatment, because sometimes they have adherence fatigue and might end up with biological failure. And this table is an example of long-acting antiretroviral therapy in development, including Cabenuva or the cabotegravir with ripivirine, which already have US FDA approved, that can be used as an injectable every 4 weeks. However, the access in resource-limited settings or in developing countries is still limited. The second group is broadly neutralizing antibodies, which has different phases of investigation from phase 1 to phase 2 or 3 in different products. And the third one is lenacapavir, in which this boy already received, which is the capsid inhibitors, which is a part of P24 protein 2, which is very important for assembly virion and on the viral infectivity. And another class of drug, which is islatravir, or combination of nucleoside transcription translocation inhibitor with the doravirine, which is the one of the promising drugs that can be used as a long-acting, like weekly, or have developed into implant. However, in December, they have a study on hold due to lymphocyte decline. But this is an example of we need a medicine that have a very potent and also long-acting, that it will be benefit for adolescent or young adult. Another case, the third one, is 17 years old MSM, his partner living with HIV. His partner just disclosed to him that he received antiretroviral drugs, even though he had viral suppression, in which we believe that it's U equal use, undetectable is untransmittable. However, when we take history of this 17 years old MSM, he has sexual debut from age 15 years old and have 8 lifetime partners. So he might be infected from other partners. So we perform HIV self-test at our clinics, in which it takes a few minutes to get result and showing that he had positive HIV self-test. So what we did is that we draw blood for HIV confirmatory test, and then providing tenofovir, emtricitabine, and DTG as a standby drug. And he go home to wait for the result. And when we get the result, we call them that he had confirmed test, and then he can start ART immediately on the same day. So this is an example of how we have integrated care, starting from HIV testing and also treatment on the same day in the same clinic. And what regimen that we use nowadays, we should use integrase inhibitors, dolutegravir-based regimen. This is the study from the Odyssey trial that was just published in December, showing that dolutegravir is a benefit for first or second line HIV treatment in children and adolescents. This study conducted in more than 700 children and adolescents, comparing dolutegravir-based and standard of care for both first line and second line regimen. And it's showing that dolutegravir-based regimen has probability of treatment failure lower than standard regimen, 14% in dolutegravir-based ART comparing to 22% in standard of care. And dolutegravir can be used in children more than 20 kilograms, and the generic drug is available at affordable price, and which is even cheaper than standard of care of ephedrins or boosted protease inhibitors. And with the more information right now, it can be used among women with childbearing age because it's less concerned on the risk of neurotube defect. And it can be used with rifampin, which is the treatment of TB, which is the common opportunistic infection. However, it have to increase the dose to 50 milligrams twice daily. And this data is shown in more details about first and second line treatment regimen. Odyssey A is the first line regimen, showing that using dolutegravir is only 6% chance of treatment failure comparing to 13% in standard of care. For Odyssey B, which is the second line in patients who already have treatment failure, 21% have treatment failure from the dolutegravir regimen, comparing to 28% in standard of care. So this thing showing that among treatment second line, it's not just the medicine itself, it's also need to address on psychosocial factors because they have higher risk of treatment failure compared to the first line regimen. So I would like to address what is the principle when we do see adolescent and young adult in our clinics. If we think about HIV treatment cascade, we would think about HIV testing, diagnosis, treatment, engagement, viral suppression, and also maintain viral suppression, in which data showing that adolescent and young adult has poorer outcome comparing to adult. However, if we think about from the client perspective, adolescent perspective, who are they? What are they need from us as a provider? They are in the unique stage of development in which the cognitive development is still in progress. In adolescent period, they have concrete thinking process, risk-taking behaviors, and also need to fit in with peers, which might not suitable with the complicated treatment or follow-up in the clinics. So we need to have regimen that is easy for them and also forgiving for them. And also as a person growing up with HIV might have neurocognitive impairment, mental health, or psychosocial challenging factors that they may have to face during adolescent period. So what is the adolescent and young adult service that they need? Data showing that the outcome of adolescent and young adults is much better if they perceived emotional and social support from the provider. It could be pediatric provider, adolescent provider, or a joint service, while they're developing skills of self-management and life skills. So it takes time during these years to be able to navigate HIV health services and also be able to have self-management. This data come from resilience study that we conducted in Thailand and Cambodia, a longitudinal cohort, and then we assessed the executive function, cognitive function of adolescent living with HIV. We have a cohort that we compare adolescent living with HIV, which represent in blue bar, HIV exposed uninfected represented in orange bar, and also HIV unexposed uninfected. And it's clearly in the graph showing that the proportion of impaired neuropsych test is 3 to 5 times higher in adolescent living with HIV. For example, attention and psychomotor speed, which assessed by color trail test, 14% of adolescents living with HIV have impaired attention and psychomotor speed. When we do DCAF study test, which assess cognitive flexibility and problem solving, almost 20% of them have impaired ability. And also the working memory that was tested by Wechsler Intelligence Scale, 12% had distracting index, which means that it's disturbed their working memory. So with all of this cognitive impair, it might have a negative impact for them for self-care, for adherence to treatment, to remember the follow-up visit, or be able to manage when things is not go along very well. The second one, important one, is the mental health. We start to do mental health screening in our clinics as a research protocol that was funded by Treat Asia. We perform PHQ-9 and GAT-7, which is the screening questionnaire that can be done while they are in the waiting room or waiting for a clinic visit. And what we find is that 11% had depressive symptoms, 70% 7% had anxiety symptoms, and 14% had suicidality. At that time, we don't have skills to taking care of these symptoms, so we refer all of them to the psychiatrist to be confirmed of mental health disorders and have a guidance of how we're taking care of our client in our clinics in the research settings. However, we find out that even though the test of PHQ-9 is quite simple, to ask for what is the symptoms in the last 2 weeks in terms of the mood, in terms of daily activities, and also the suicidal ideation. But the important thing is not just the screening, but in terms of how we're taking care of a child who have symptoms, or how we provide integrated care. So we decided to do a capacity building for our staff in the clinics to be able to have a skills to do counseling, to supports, and also have a safety plans in case that participants have suicidality in order to manage if they have suicidal attempt or event, to detect warning sign, to have coping strategy, or how to call for help. And then we integrated called collaborative care model to integrate mental health service into our clinic, not refer them to the psychiatrist because we have limited working staff of psychiatrists, and also it have a stigma of referring our clients into psychiatric clinic. So with a model that was written from the developmental schema showing that mental health care can starting from the community, from the primary care service or in general hospitals or general service, and then refer them to the psychiatric service if needed for the complicated case. So we use this concept, and we have psychiatrists to be consultation and train our staff, which have variety of staff from pediatrician who be able to prescribe medicine for treatment of depression, anxiety. We have a psychologist to do counseling. We have a peer supports to manage or help them to be able to talk about mental health issues in our clinic. So we expand clinics from not only screening PHQ-9, but be able to do a protocol to provide counseling and basic pharmacotherapy. So 1 year that we implemented this program, we're showing that from about 400 youth clinic in our service, 12% had PHQ-9 more than 10, which have depressive symptoms, and 1% have suicidal attempt. However, comparing to the first study, nowadays, 70% of mental health care was performed within our integrated care and with the supervision of psychiatrists, and only complicated case was referred to psychiatrist. So what we have in our clinics provide service to adolescent and young adult, and have clients that including early acquired, perinatally acquired adolescent living with HIV, or acquired later in life through the sexual transmission, and also to provide service for at risk of HIV acquisition, adolescent and young adult. So it's not stigma. So people to come into our clinic doesn't mean that they already have HIV. They just come for many consultations. And the service that we have wide spectrum from sexual health, STD, gender affirming care, contraception, mental health, psychosocial support, and also address about 10% using substance abuse in our clinics through the integrated service, and also consultation integrated in our care. So it's starting from reach and recruit adolescent into clinics and evaluated 3 important things: HIV risk, STI, mental health problems. And then we use HIV self-testing in clinics as a point of care testing in order to triage them to go into HIV treatment cascade or HIV prevention cascade, and offer PrEP if they have high risk and interested to take. So in our clinic, we have called CU Buddy Clinic. So it's anonymity and not create stigma. It have a flexible time service. And during COVID, we also have a teleconsultation or have peer engagement team to texting and keep engaged with our clients. And our staff was trained to understand the unique aspects of adolescent and young adult, and be able to provide as a one-stop service, to emphasize on using point-of-care testing in order to have everything in one-stop and same-day ART. So this is our staff, which is friendly and also in the concept of peers and open-minded staff to be able to listen and support them. The HIV testing service that we integrated, there are two unique things. The first one is social network-based approach, that we also allow them to invite their friends or peers to come into clinic and get HIV testing. Because what we know is that within their own social network, they have increased risk, increased opportunity to bring in adolescent in the same sex network that might be the same risk for HIV acquisition or maybe HIV positive in our clinics. And also we use HIV self-testing, the test kit that we use, both blood-based and oral-based HIV testing as a point-of-care testing in our service to be able to get quick result and also save time of staff to do more on the cascade, either prevention or treatment. So do adolescents like HIV self-testing? Do they like blood-based testing or oral fluid-based testing? So we conduct a pilot study to perform acceptability of blood-based HIV self-test kit that they need to do their own blood stick and then their own test and interpretation. What we find is that acceptability is quite good, but for the adolescent and especially for the HIV first-time tester, they prefer to do in hospital rather than bring it at home and doing in private. And one of the problems that we find for invalid tests is inadequate blood volume, because it's quite challenge for adolescents to be able to do a test by their own or to collect enough blood. So we think that, or they like oral-based HIV testing. So we do another pilot study to ask for the prevalence between oral fluid versus blood-based HIV self-testing. The oral fluid-based is easier to collect sample. However, it takes 20 minutes to get the result, comparing to blood-based, which might be difficult in terms of blood stick, fingers prick to get blood. However, it takes only 1 minute to get the result. So what do you guess? Which one that adolescents prefer? What we find is that 2/3 of adolescents prefer blood-based tests because they say that it have quicker or rapid result and also perceive that they have higher accuracy. However, during COVID era, when we use more ATK or test kit that we collect saliva, it might be have more sensitized of using oral fluid based to test or screen for HIV. We have to wait and see how it's growing when we have interface with COVID, that ATK or saliva-based testing is more widely used and more accepted. Another HIV prevention service that I would like to address is HIV PrEP and also STD treatment, screening and treatment. So our prevalence of STD in our clinic is quite high. The prevalence is about 22%. The three most common is C. trachomatis, syphilis, and Neisseria gonorrhea. And what we find among MSM, the rectal infection is quite high, in which sometimes even rectal gonorrhea is asymptomatic that need PCR for testing, which is still a limitation because the STD testing with PCR-based test is still expensive and not widely available. However, it's very important to treat STD to prevent inflammation or also that could have increased risk of HIV acquisition. Another one is PrEP. When we're thinking about daily PrEP, we're afraid that adolescents will not comply or adherence to regimen. So we have a pilot project that was conducted in adolescent 15 to 19, led by Dr. Vipapon. And we work with a very high risk cohort, the HIV prevalence is 6%. And for HIV negative, high risk of HIV acquisition, we enroll them into once daily tenofovir FTC PrEP with monthly contact by phone call or clinic visit. What we find is quite positive findings. 73% of adolescent retention in PrEP service up to 6 months, no HIV seroconversion. And if we see in details of blood level, about 50% have very good adherence, have blood level of TFVDP above 700 femtomole per punch, which correlated with very high effectiveness in prevention of HIV. And also we encourage them to use condom. About 1/3 have used condom regularly. So within this integrated prevention for both condom use, PrEP, and also HIV risk behavioral counseling, we be able to prevent no HIV seroconversion. However, after stop in the protocol with less frequent follow-up, and also with the COVID, with disrupted in HIV services due to the restriction in clinical visit, we find that some of them had seroconvert. So it's mean that adolescent PrEP service, you be able to support them to get good adherence. However, the period of time need to be in a longer period of time to make sure that be able to reduce risk of HIV, or be able to use condoms or combined use of PrEP with good adherence. So I would like to conclude that adolescent integrated service that we create to provide service spectrum from HIV testing, prevention, and treat can be performed with the concept of youth-friendly service, that we understand developmental and adolescent period and be able to support emotional and socially while they develop life skills. I think the retention is the most important, more important than virological suppression. Because if we put our service that we be like a shade of tree for them to be able to come back to our service and forgiving and understanding that there are many things happen in their life, but we be able to support and have service for them. It's very important. And we have to be very sensitive to stigma and privacy, which is a very important and crucial when we deal with adolescent. We should reach and demand creation by asking adolescents themselves to be able to have a referral or even recommend friends into our service, and also have multidisciplinary team and one-stop service model to support them. And hopefully, I think adolescents would be able to navigate themselves to be able to have HIV-free if they are at risk and not acquiring HIV yet. However, if adolescents living with HIV would be able to be supported, treated, and be able to have a transition into adult with a good quality of life. And at the end, I would like to thank and acknowledge my team at Faculty of Medicine at CU Buddy Clinic that integrated their work and also sharing their work that I presented today, and hopefully that it will be benefit some of you to use this idea to create adolescent integrated service in your setting. Thank you very much.